Ultimately, I think the failures we've seen in minimal access spine surgery are because, one, it was gimmick-based, two, you frequently compromise the objective to achieve the result. I think using an interpedicular approach, using a pedicle screw-based stabilization and neuronavigational approach, and a segmental approach, you don't compromise anything. And you know, we've talked about ALIF versus posterolateral or transforaminal oblique lumbar. I don't see the point of going ALIF if you can do it from a posterolateral or even a T-plip perspective. For me, it's become very easy to do a transforaminal, even in mid-thoracic. Aside from that, the complication management, because of a lateral versus medial approach, redos become so much easier. Even if it's a redo, once you have screws fluoroscopically placed, whether you have scar or not, you know exactly where you're going, and you can go through it in phases using the anatomical landmarks straight to the foramen. You don't have to worry about midline scar. You don't have to worry about extensive dissection of the thecal sac. It's very anatomically pure. It's 100% reproducible. And so redos become as easy as first time, and ultimately even easier if your target area is reduced. And for that reason, I think using the interpedicular approach gives you just an effortless navigational, anatomical direction to target what you want to accomplish. Our strategy as we look at any of these patients, and it's a broad group of patients, basically what we're doing is focusing on the actual nerve root incriminated in the pathological process. Whether we treat that in the central canal or lateral recess, or more specifically which segment of the lateral recess, varies very, very specifically from one circumstance to another, from one intervertebral unit to another. The days of doing a broad, multi-level midline laminectomy so that you can start to approach the foramen in an exploratory type fashion, I think, are numbered. As high outcome, minimally invasive spinal decompression reconstruction surgery becomes more and more popularized, we're going to be better and better on the clinical side, on the preoperative planning side, and at identifying which nerve at which location is critically stenotic and affected, and consequently not unroof and manipulate and potentially damage everything just to sort of a shotgun approach to decompressing something that you know is not working well. There is no question that intuitively speaking, if you're doing smaller exposures, less muscular damage, less muscular necrosis, more opportunity for rehabilitation and strengthening, intuitively we're not going to see as much next level phenomena. And that, at the end of the day, that I think is the goal of interpedicular minimal access surgery.